host, Dr. Aziz Nazha, will present the concept and the subject of today, and then I'll take over to present the first speaker. Aziz.
Thank you, Ahmed, and thanks for all of you for joining today. Such a great pleasure to see all of you. We started this series now going back in June, I think it was the 1st or May, the first time when we started it, and the idea to bring AI, and we try to understand how AI applied in hematology. And we were lucky to have the Saudi Society of BMT sponsoring this events. And this is number 5 events, and I think we have seen great attendees so far in those sessions, and we want to thank you for your attendance. It's been really great to see all of you joining today. But the idea is we try to have a discussion about specific topic in hematology. Sometimes we talk about AML, MDS, and other diseases, and then how do we apply AI in that disease? And I think this methodology has been very powerful in a way that it gives education about the disease, but at the same time, how AI can be clinically or practically applied. And today we have a great session for you, because we will be talking about the role of AI in post-transplant complications in chronic graft-versus-host disease. I have a great speakers the first speaker going to talk about transplant in general, but the second one will talk about AI. So I'm very excited about this session. I'm very excited to see you today. And at the end, typically we have about 20-25 minutes for open discussions and questions. I encourage all of you to ask questions as we moderator ask the questions at the same time. So hopefully we get more participation this time from the audience. So Ahmed, we'll put it back to you to introduce the first speaker.
Thank you, Aziz. And allow me just to mention something that you told me. I think we should be all proud here and kicking this activity off. Aziz was telling me that he was trying to take us as a model to sell such a model and for the ASH, and telling them that we already started doing something like that in Saudi Arabia. So I think we should all be proud of this, and hopefully the benefit will extend to everybody. Again, without any further delay, it's my pleasure to present my friend, colleague, and actually neighbor in my office, Dr. Samir Al-Amoudi. He's a consultant hematologist, bone marrow transplant, and the section head of cellular therapy at King Abdulaziz Medical City in Jeddah, Saudi Arabia. Our center is pretty active. We do pretty much all kind of transplants, including cellular therapies and CAR T cells. So he has been leading this program right now for several years. So there's no one, I think, better that could have give us this overview about the clinical decision process, decision-making process in the cellular therapies transplant in general. So predicting the right donor, predicting the toxicities, predicting the acute and chronic GVHD, and post-transplant complications. So Dr. Samir, all yours.
Assalamu alaikum. Hello, everybody. Thanks, Dr. Absi, for the nice introduction. And thanks, Dr. Aziz, also for moderating the sessions. And also I want to thank the ISSBMT and Sanofi for sponsoring this meeting. So let me share my slides. So can you see my slides?
Not yet.
Okay. Can you see it?
Yeah, now we can see them.
Okay, fine. So in the next 20-25 minutes, I will give an idea about overview of clinical design making for donor selection, conditioning, regimen decision, and post-transplant monitoring. So this is actually usually in daily practice, we face this scenario actually. So which is the best donor, what's the best conditioning, and how to follow up the patient post-allogenic stem cell transplant. So let's start the scenario by a case. So actually, this is a real case. So this is a 22-year-old male, actually, with a relapse pre-BLL, Philadelphia negative. He was actually initially diagnosed 2020, treated with CLGB protocol, completed in October 2023. Later on, almost after 1 year, he relapsed with November 2024. At that time, he was salvaged with inotuzumab. Actually achieved CR2 with negative MRD. What is the next step? So given this adult patient, next step will be allogenic stem cell transplant, and this is actually based on this article. So it's indication for hematopoietic stem cell transplantation for hematological disease, solid tumor, and immune disorder. Current practice in Europe 2022. So what's the goal of hematopoietic stem cell transplant? So actually the goal of stem cell transplant, we're focusing here about allogenic stem cell transplant. Actually, it's replacing diseased marrow with healthy one, provide rescue after myeloablative conditioning therapy, and which is the most important thing, which is establishing the graft versus leukemia effect. As we know, the cancer cells escape the immune system. That's why with allogenic stem cell transplant, we are aiming to introducing a new immune system, and also restoration of normal hematopoiesis in case of bone marrow failure syndrome. This is mainly in the benign cases. So this is actually the trend of stem cell transplant in allogenic stem cell transplant in CIBNTR data, and you can show here the most 3 common causes for allogenic transplant is acute myeloid leukemia, acute lymphoblastic leukemia, and MDS/MPN. This is the journey for the patient. If the patient is going for allogenic stem cell transplant, so this is the journey usually the patient will travel through. So once actually we identify a patient that are eligible for allogenic stem cell transplant, first of all, we need to look for HLA typing for the donor. Of course, there is multiple donors, so we have to identify the best donor for this patient. Once we identify the donor, we need to select the best conditioning therapy. And once the conditioning therapy started, actually, and the source of stem cell needs to be decided either peripheral stem cell, bone marrow, or from cord. After the infusion, the patient will be followed before the engraftment for febrile neutropenia or any toxicity relating to the conditioning. After engraftment, the patient will be followed for long-term toxicity, acute and long-term toxicity post-engraftment. So let's start by the first step, which is actually the HLA typing. So as you know, usually look for HLA major MHC complex, which found in human chromosome 6. Actually, there is 2 classes. Class 1, which is HLA, HLA B and C, and class 2, which is HLA DR, DQ, and DB. And type of donor, actually either to be like HLA identical donor, 10 out of 10, siblings. So usually sibling, actually, we need 6 out of 6 is enough. For match unrelated donor, the donor there should be 10 out of 10. Mismatch donor, which is less than 10 out of 10. Haploidentical donor, especially here in Saudi Arabia, we do a lot of haplo donor because it's difficult to find match unrelated donor. So haplo donor will be 3 out of 6, so which usually the donor will be either the parent, siblings, or the child. So let's back to our case. So actually, there was 3 HLA identical siblings that were identified, 2 brothers, one of them age 24, the second one 40 years old, 1 sister, her age 35, and 1 haplo donor, his brother. So now we have a donor, so which is the best donor to use for this patient? So here came the donor selection. There are actually several factors to determine which is the best donor. So there is non-genetic factors like the age, the gender, parity, CMV serostatus. In case of haplo transplant, presence of donor-specific antibody. Of course, donor availability, that's as mentioned earlier, like in case if there is no match-related donor, we'll go for haplo. because it's not easy to find much unrelated donor. And of course, stem cell dose and germline predisposition. Other HLA factors like DPP1, non-HLA genetic factor, ABO types. So it's well known, like HLA match 8 out of 8 actually is better, or 6 out of 6 better compared to mismatch. And actually, you can see here clearly from the chart, any actually mismatch, it leads to decrease the survival by 8 to 12%. And any additional mismatch, it leads to decrease more in the survival. What about CMV serostatus? Actually, this showed that if the recipient CMV negative, so the donor, if the patient actually, the patient CMV negative and the donor CMV negative, they do better compared if the donor is CMV positive. Here, actually, in Saudi Arabia, rarely to see patients with CMV negative, especially in the adult populations. So the majority of the patients, they are actually CMV positive. And why it's important to know that? Because it's well known, like actually, if the donor, the risk of CMV reactivations is higher if the donor actually CMV negative while the recipient is CMV positive. So the best donor will be CMV match, ideally to be CMV negative. If the CMV negative not available, so the ideal will be CMV match. So either CMV positive, both donor and the recipients. Why is that important? Because any CMV replication actually associated with increased mortality, as you can see here, because this is one of the things that you follow the patient post-engraftment. What about the blood group? So the blood group, actually, you have something called major mismatch and the minor mismatch and bidirectional. So in the major mismatch, actually, the issue of doing like to collect from a donor, the major mismatch is the acute hemolytic crisis, delay RBC engraftment, Burette cell aplasia, which can happen actually with the minor mismatch, but the lesser percentage. Actually, there's a solution for that. So in the major mismatch, actually, there will be like red blood cell depletions. In case of minor mismatch, in stem cell process, they will do plasma depletion. So it's not a major concern, especially in the case of acute leukemias, especially with the stem cell processing. So there are many studies actually mentioned, actually, some of them they are positive, some of them are negative about the survival of the ABA-incompatible stem cell transplant. So what about gender mismatch? So usually the male donor actually is better compared to the female donor. Not only that, if you have two female, one of them are nulliparous, the other one multiparous. So the nulliparous donor is better compared to multiparous. So this is one of the things actually we look at during the selection of the donor. What about in case of haplo donor? So in the haplo donor, if you didn't find any match-related donor and you're looking for haplo donor, the most important thing is to look for, is there any availability of DSA and donor-specific antibody? Because the patient is having donor-specific antibody, this will be not the best actually donor, because this, if you use stem cell from this donor, it will be rejected from the recipient. Of course, there is more details about the titer of the antibodies. So in clinical practice, if that less than 2,000, the titer antibody is not significant. More than 10,000, actually this donor will be excluded. Between 2,000 and 10,000, it's case by case. So sometimes you can do sensitization to the recipient and you can use that donor. But if more than 10,000, this donor will be excluded. Other factors, the same, the age, gender match, CMV match, and ABO compatible. So this is actually like a donor selection flow chart. So once you identify, you usually do screening for HLA typing. Usually you do screening will do HLA, it's actually LA, B, and DR. So this is like a screening, especially for the donors. If the 6 out of 6 identify match-related donor, so we'll use that donor. In case we don't have match-related donor, the options here actually, I'll say now our institution, either the match-unrelated donor or haplo. Cord blood, we don't have any cord blood actually in our institution. But it's easy to find haplo donor compared to match-unrelated donor. So option number 2, in case if there is no match-related donor, we'll go for the haplo. If the haplo is not available, or there is like a, for example, DSA, we'll start to look for match-unrelated donor. So let's go back to our case. So as I mentioned earlier, he has like 3 HLA siblings and 1 haplo donor. So based on the factor that I mentioned earlier, so we'll exclude this, the female. We'll exclude the haplo donor because we have fully matched donor. So now we left with 2 HLA matched brother, one of them age 24, the other age is 40 years. So these are like the other factors that can help the physician to decide which donor to use. So our patient is age 22 years old, male, blood group O positive, and CMV. As I mentioned, majority of patients are actually CMV positive. The first donor, which is the young one, around 24-year-old, is having the same gender, same blood group, same CMV status. The donor number 2, elderly, 40 years old, same gender, different blood group, but same CMV status. So for this reason, we'll exclude actually this. So we'll select donor, the younger donor, because of the age and the difference in the, because of the ABO mismatch. So as I mentioned, we'll use this, the younger HLA match donor. So we selected the donor. Now the question about the conditioning regimen. So usual conditioning is the chemo that we give it before infusion of the stem cell. And the aim usually of the conditioning actually several aims actually to ablate, myeloablate the bone marrow. So it will help the stem cell to go there and start to produce the hematopoietic cells. And also if there is any remnant cells, the cancerous cells actually, which wasn't taken care by the salvage therapy, the condition will help in that. So there are different regimen actually of of the conditioning regimen. There is something what we call the myeloablative regimen. So in myeloablative, that means the stem cell, the bone marrow will not work again unless you give stem cell rescue. So example for myeloablative, like cyclophosphamide TBI, BuCy, and FluBu. Non-myeloablative, so you give the conditioning, the therapy, but this does not treat the stem cell rescue. So even if you did not infuse the stem cell, at that time, the bone marrow will work again. So RIC, it's between the myeloablative and non-myeloablative. So regimen intensity, so myeloablative, it increased the transplant-related mortality, but decreased the relapse. Non-myeloablative is the opposite. So it decreased the transplant-related mortality, but increased risk of relapse. Reduce intensity, actually, it will increase the end-organ toxicity, infection, and increase risk of graft versus host disease. So you have a patient going for transplant, so you have to decide and balance the risk between the efficacy of the conditioning and toxicity of the conditioning. So how can you choose the conditioning regimen? So actually there is like, it depends several factors based on the diagnosis. For example, if the acute myeloid leukemia, we prefer myeloablative. In case of a benign disorder, you can use actually non-myeloablative regimen. Remission status, in case of the patient achieving, for example, in case of acute lymphoblastic leukemia, achieving remission, but still MRD positive. So these types of group actually we prefer to give myeloablative. Donor availability, because we know like it depends on the type of donor, you would choose the conditioning graft source. So usually in case of malignancy, we prefer stem cell collection because the source, because this actually will because we want the GVL effect, which is higher in the peripheral stem cell collection. In case of benign disorder like sickle cell anemia or aplastic anemia, we don't want any GVL effects. That's why we'll go with the bone marrow harvest. Of course, comorbidity. If the patient is having any comorbidity, this will it will be difficult to give myeloablative conditioning. Age, younger patients, they can tolerate actually myeloablative regimens. So our patient actually is relapsed ALL. Remission status is in CR2 with MRD negativity. Donor, HLA match donor. Source of the stem cell will be peripheral because we need GVL effects. Is young. What about the comorbidity? So actually, this in general, like any patient going for allogeneic stem cell transplant, there is like a pre-transplant workup just to be sure this patient is fit to go for allogenic transplant. So usually do pulmonary function tests, we do echo, check the renal and liver profiles, do dental clearance, and of course there is psychosocial consultation. And one of the actually factor to assess actually the patient fitness, actually there is something, and the transplant related complication is called hematopoietic stem cell transplantation comorbidity index. So this actually score, it's like several items, and based on the score, usually it's more than 4, we prefer not to give myeloablative regimen because the patient will be higher for transplant-related complications. So this is the score actually. You can see it's including arrhythmia, cardiovascular comorbidity, valvular heart disease, stroke, pulmonary dysfunction, either moderate or severe, hepatic comorbidity, mild or moderate, peptic ulcer, renal profile, hematological disorder, diabetes, inflammatory bowel disease, psychiatric disorder, obesity, infection, and biliary malignancies. So if you look, our patient actually has 0. He did not have any of this comorbidity. So that's why for this patient, he's young, fit, we decide to give myeloablative regimen. So one of the things that actually you can keep it on your mind about the GVHD prophylaxis, we have several medications, GVHD prophylaxis, and several regimens. For example, calcium inhibitors, methotrexate, antibody like ATG, mycophenolate, and post-transplant cyclophosphamide, especially in case of the Hablo. Actually, post-transplant cyclophosphamide as GVHD prophylaxis actually is improve actually and it actually decrease the incidence of graft versus host disease. So our patient underwent multi-sibling donor allogeneic stem cell transplant. Conditioning was cyclophosphamide TBI, myeloablative. Both donor and patients are ABO match and CMV match. GVHD prophylaxis, which is the standard for TBI, it's cyclosporin methotrexate. So conditioning giving the stem cell infused, and usually during before engraftment, we are watching the patient for any febrile neutropenia. And if the patient actually engrafted, at that time we starting looking for the toxicity. So this is actually like it's from the EBMT actually, and just give an idea that about monitoring the patient post engraftment. And basically, in the first 100 days, usually you will assist the patient looking for any like evidence of acute GVHD, any evidence of relapse disease, and also the organ function, and looking for reactivation of any CMV. After 3 months, you start looking for any evidence of chronic GVHD. Long-term follow-up actually usually sometimes do it annually, looking for any long-term complication from transplant. And here actually, you can see the details about how to follow the patient in each organ as mentioned in the EBMT handbook. So allogeneic stem cell transplant, it can cure patients, but actually it carries risk actually in the same time. You can see here actually this is the cause of death after match-related donor in US based on CIBMT. That actually you can see the either within 100 days or after 100 days. Usually either the disease itself, graft versus Hello? So this you can keep it in your mind when you discuss with the patients about that transplant.
Doctor, sorry, can you share your screen again?
Sorry, okay. Can you see?
Dr. Samir, we cannot hear you.
Okay.
Now, can you see it? Can you see my slide?
Yes, doctor, but just click the presentation mode. Okay, perfect, doctor.
Okay. So as I mentioned, that one of the things that you have to discuss with your patient about the complication from the transplant, including infection, organ dysfunction, and graft versus host disease. So acute GVHD can affect 3 organs classically, which is the skin, liver, and GI. So usually in the first 100 days, we're looking for any skin rash, any abnormal liver enzymes, or diarrhea in case of lower gut GVHD. Why it's important? Because actually it's clearly mentioned that if the patient develop grade 3 or 4, actually graft versus host disease, actually this translates into increase of transplant-related mortality. What are the risk factors for acute graft versus host disease? HLA disparity, which is the most important risk factor. Stem cell source. So peripheral, if you collect the peripheral from the stem cell from the peripheral, actually increases chance of graft versus host disease compared to the bone marrow harvest and umbilical cord. Gender mismatch. So myeloablative conditioning.
Dr. Samir, we don't see your slide.
Actually, Dr. Samir, we don't see your slide. Oh.
And if you can finish within 2 minutes, please.
Okay, sure. Can you see it?
Okay, doctor.
Okay. So as I mentioned, these are risk factors. Our case actually is like HLA match, peripheral stem cell collection, gender match, and the typical actually donor. So the patient develops skin acute GVHD stage 1, resolves with local hydrocortisone, and start tapering with cyclosporin 27th of April. After that, by 2 months, actually was admitted with short breath, dry cough, required high flow nasal cannula in the ICU. Adenovirus PCR was positive, so impression initially was viral pneumonia, and this is the CT chest. So actually, I've started antibiotic, but bronchoscopy was done, came negative, so the impression that time changed to this is lung GVHD. And we know that chronic GVHD is one of the complications carry like increased transplant-related mortality, and just will skip that. So there is criteria, NIH criteria about how to diagnose chronic GVHD. And let's go back, and there is
We don't hear you again, Dr. Samir, but I think Aziz, if you can present Dr. Roni, and then we let Dr. Samir to summarize during the discussion.
Great. Okay, thanks, Dr. Samir. And then it's really my great pleasure to present Dr. Choval. So Roni Choval is an assistant attending in the bone marrow transplant and cellular therapy service at Memorial Sloan Kettering Cancer Center, and he is assistant professor of medicine at Weill Cornell Medical College. He directs the Precision Cellular Therapy Lab at MSK, leading research that integrates genomics, immunology, and AI to improve outcomes in CAR-Ts and stem cell transplantations. Dr. Chauval's work has advanced understanding of resistance and toxicity in cellular therapies and has been published in top journals, including Nature Medicine, JCO, and Blood. He also served on the scientific committee of the American Society of Hematology and the European Society of Bone Marrow Transplantations. He's a great friend we share, and he's part of the American Society of Hematology AI subcommittees. So it's really my great pleasure to introduce Roni, who will be talking about a multimodal approach for precision cellular therapy. Thank you, Roni.
Thank you, Aziz, for the kind introduction, and thank you, Ahmed, and thank you, Aziz, for inviting me. It's really a pleasure. And I'm going to talk about cellular therapy. That is sort of the natural evolution, I would say, of allogeneic hematopoietic cell transplantation. Although I may, if I have time, I'll talk specifically more about allogeneic transplant, but the main talk is going to focus on CAR T cell therapy. Here are my disclosures. So what are CAR T cells? When we think about CAR T cells, these are virally transduced T cells or genetically modified T cells. And what we do in the process of manufacturing them is usually we take from a patient, collect T cells, we virally transduce them to express a chimeric antigen receptor that has an internal part, which is part of a T cell receptor, and then a short chain immunoglobulin section part that targets an epitope, like a flag, essentially, on the tumor cells. These cells are expanded out of the patient. It takes about 2-3 weeks to produce. And then after the patient gets some chemotherapy, it's called lymphodepletion, the cells are infused and engaged with the tumor cells, as you see here. Once they engage, they start to proliferate. They excrete cytokines, which lead to tumor cell death, essentially, and ablation of the tumor. Now, this treatment has really changed the landscape of, or the treatment landscape of hematological malignancies. I'm showing you 2 commercially approved CAR T cells, one for large B-cell lymphoma, axi-cell, and the other for multiple myeloma. They have different target. One is CD19, one is BCMA CAR. And what I want to show you here is essentially giving a CAR T compared to standard of care significantly improved progression-free survival in patients that had relapse disease or refractory disease. So clearly it's a transformation and expanding to many other indications, and it's a revolution in the field. However, when we think about CAR T cell therapy, which is again a part of cellular therapy, we still have many challenges. And the challenges could be sort of divided to 3 main parts. One is access. So many of the patients that actually have an indication to receive CAR T cells do not eventually get it. It's a very expensive treatment. It's logistically complex to provide it. The reality is that a lot of even countries do not have access to it, and even patients in the US. The second is toxicities. There is a broad range of toxicities, starting with cytokine release syndrome, which is essentially a severe inflammatory reaction, which could range from a fever to multi-organ failure and death. Or there is neurotoxicity, which we call ICANS. And there are many other types of toxicity, which I'll show later. And then the last challenge is resistance. So many of our patients still relapse or progress after CAR T cell therapy. And when you think about what are the drivers of these challenges, I would say, it's a combination of the immune system, of the tumor, and the host. And the way we see it in the lab, at least, is, in order to understand and decipher these and tackle these challenges, we need to harmonize the different aspects and to lead us to precision cellular therapy. And I'll show you some works that sort of involves AI or machine learning to sort of solve some of these or investigate some of these challenges. So the first project I want to discuss is called cartography, and this clinical lead here is Kai Rajewski, and the statistical lead is Dr. Tang Fei. where we sort of wanted to take a different approach for mapping toxicities of a CAR T cell therapy. And we want to build like an atlas, a single-day atlas of toxicities in CAR T cell therapy. Why did we want to do it? Well, typically when people have studied CAR T cell therapy, they focused on one toxicity or one domain separately. Let's say CRS, cytokine release syndrome, or immune effector cell-associated neurotoxicity, ICANS, or infections, or cytopenia. But our hypothesis is, in fact, toxicities are in fact interdependent. They're connected to each other, and there are toxicity syndromes to a great extent. And when we view them just by the eye or look at the one element separate than the other, we're missing, we see the trees, but not the forest. So to do that, the first thing we did is actually we needed to compile a map of toxicity at a very high resolution level. And we took 900 patients. Now it's actually around 1,300 patients from multiple centers across the US, Europe, Israel. We took different CAR T cell products, all commercial. And for these 900 patients, we had a team of 12 investigators who curated on a day-to-day basis using standardized criteria the grades of toxicity, whether it's a neurotoxicity, CRS, cytopenias, which is ICAT, and infections. Now, this is a complete opposite of machine learning or AI. It took more than 1,000 hours of data entry just to collect these data. But what it allows us to do is essentially get a very large database, essentially, from translating from about 30,000 patients' days to 125,000 data points, because each day had multiple axes of toxicity. And having such a high dimensional, very complicated data sort of allowed us to study CAR T cells and toxicities in a different way. So the first thing was, how do we even deal with this level of data and so complex data? And we had to think of ways to organize it. And this is like a lesson, essentially. Whenever you're doing machine learning project, or the first thing is to understand your data and clean it and harmonize it. And Tang, with the statistician, sort of came up with a way to visualize the data. The first way was to sort of divide it. You see here blocks, right? And each block is a domain of toxicity. Each column you see here is a day relative to CAR T. So day 0 is the day of infusion up to day 30. Each row here is a patient. And it's very hard to see, but you see the colors there, the tiles, are in fact the grade of toxicity per day. So the darker, the higher toxicity. If it's black, it's grade 5. So it means death from the toxicity. And then if it's dark red, then it's a lower grade. And then we could sort of see how the toxicity sort of evolves over days. You could see that some patients really are all red, right? And some patients are just sort of lighter. You don't see as much colors. I see there is a question. Do we take questions now, or I'm happy to answer.
It's toward the end.
Towards the end. Okay, no problem. Okay, great. So great. So now we have this, we have the infections, the cytopenia, then neurotoxicity. Okay, let's re-aggregate it and think about how to think about it in the population level. So in order to do that, we constructed a histogram of toxicity per day. So you can see here the daily toxicity. So it's not the max toxicity. It's by day toxicity, showing a histogram essentially of the grades that we see each day. And for instance, for cytokine release syndrome, we see it's early. Most patients experience it early. For infections, you see that it's, sort of, there is a tail. Up to day 30, you still see infections, cytopenias, ICAT as well. And then you can ask, okay, what's the cumulative incidence of a certain toxicity? For me, what was surprising is that, in fact, the cumulative incidence of grade 3 infection, meaning severe infections, was about 25% in this cohort. This is high, right? So then, okay, just sort of thinking about what was our initial concept, we thought there are prototypes of toxicity. So here is where it becomes a bit more machine learning or AI based. Okay, so how can we understand these trajectories, right? It's very complicated. We have multiple axes. How can we think about the data? And the data is complex because you have multiple dimensions, right? Multiple days. So you need to aggregate to take into consideration the different grades of toxicity and the time. And we need to find groups. So for that, we used a clustering algorithm, meaning an algorithm that looks for patterns in data. It doesn't matter. It doesn't ask what are the outcomes. It's just trying to find order within the data. It's called latent trajectory clustering. That is, and the name is not very important, but what I want to show you here is that you see here, each of these are the three clusters. Each row is a cluster, and the smear that you see here sort of reflects the average toxicity per day for each domain of toxicity for CRS, ICANS, and infections. And you can see, for instance, what we call the high toxicity cluster. It's also very red, especially in the ICAT, in the infections, in the CRS. So we call it high toxicity. There is sort of an intermediate toxicity, and then there is a low cluster toxicity, which you see it's very light. It's blue or gray, so very mild toxicities, some CRS, some ICATs, barely infections. And the next question, so this is unsupervised, right? It's we look for pattern. So the next question is, so what? What does it even mean for the patients, right? And we looked at it in various ways, trying to adjust for potential confounders and the time effect. But anyway, what we found is that patients assigned to the high toxicity cluster had the worst progression-free survival, the overall survival, compared to the sort of cluster 2, mid toxicity and low toxicity. And this was, this means it has some prognostic impact. And what was driving a lot of it was non-relapse related mortality. So patient dying from their treatment, which is not something that we want with CAR T cell therapy. It's supposed to be curative. Patients should go home at the end of the procedure. So then, the question is, how can we take this cluster and learn something about the biology of these different syndromes? And to do that, we used a proteomic platform called Olink. This is in collaboration with LMU Munich, University of Munich, where what we were able to see is that even before you get the give the CAR T cell infusion, you see that patients in the high toxicity cluster have increased interferon gamma signaling, or increased interferon gamma essentially in the blood, even before CAR T, and this actually persisted over time. So you could see here it's a cluster 3, the high toxicity. In the first week or so, they had higher interferon gamma compared to the others. And this is important because this is potentially targetable. Now, you could sort of ask yourself, okay, this is one element or some we can do with the data, learn about the biology of toxicities, but we also want tools to actually manage the patient. And this is a very rich data set, very comprehensive. And, the ultimate clinical question is, who would develop CRS or neurotoxicity or ICANS or infections? And this is important because we have interventions, right? If a patient is about to develop CRS or ICANS, we could give tocilizumab, anti-IL-6, which is a driver of CRS, or steroids for ICANS. We could decide whether to give the treatment outpatient or inpatient. At Memorial Sloan Kettering, we are doing some of the CAR T cell outpatient. So you could think about, okay, this patient tomorrow is going to develop CRS, and we'll admit him. So here we use what is called like a supervised learning approach, where we learned from a training set where we have the labs, the daily toxicities, medication. We learned the connection between these and the outcomes, various outcomes, CRS, ICANS, etc. And then we try to project that on future patients. So what would happen in like our test set, essentially. So you learn the relationship and then apply it. So this is called supervised learning. And we used a method called recurrent neural network, specifically long short-term memory algorithm of neural network, which what it helps you is to take into account serial prediction. So It's used, for instance, sometimes in the stock market. If you want to predict the price of a stock in the next day, you take the historical data from the last few days and you try to project what will happen tomorrow. So a very similar approach was used here. And without going too much into the details, what I can show you is that we achieved reasonably good accuracy using this approach. So this is one application that we're doing with specifically AI, but I want to sort of take you to a different aspect that sort of touch access to some extent and toxicity. And this is work done by Sean Paulson and in collaboration with Kai Rajeski and Greg Golgoff. And I want to start with a premise here. So we know that, or we aim to monitor our CAR T-cell patients using methods for immune monitoring. And we have several tools. We have PCR to follow the CAR T-cell transcript. We could use flow cytometry, these are both clinically available, but then there are much more sophisticated methods such as single-cell RNA-seq. And then there are very simple measures such as just looking at the absolute lymphocyte count. However, the absolute lymphocyte count really gives you very low resolution on what's going to happen. And then single-cell RNA-seq, it's not practical in day-to-day. It's very expensive, requires a lot of technical skills. Flow cytometry and PCR, are more expensive than just having an absolute lymphocyte count. They require some technical infrastructure and skills to do that. And many centers that do follow immune dynamics after CAR T-cell infusion use these, but they typically do it, on day 30 or day 14, so intermittently. So you don't get the full picture of what's going on. And some use, for instance, the absolute lymphocyte count, but what I want to show you here is that using the peak absolute lymphocyte after CAR T in large B-cell lymphoma doesn't really help you distinguish between who will respond and who will not respond to CAR T, as opposed to probably PCR or flow. So this is, one thing you need to remember, right? So these are how we currently monitor. But we had an hypothesis that essentially we could use, or the lymphocyte morphology in the peripheral blood, when we look at the lymphocyte, it actually encodes for the activation, differentiation, and dysfunction. And therefore, if you look at the lymphocyte in the peripheral blood, you can actually use it for immune monitoring, and specifically CAR T cells. And why are we saying that? Well, first, we know that morphology, right, is an indicator of viral transduction. You can think about this is a image from a patient with infectious mononucleosis secondary to EBV, right? These are the lymphocytes in the peripheral blood. They're very aberrant. They look very weird, right? And these are virally produced cells or lymphocytes. And right, CAR T cells are also virally transduced. So this is point one. Point two is that there have been reported very small studies looking at peripheral blood smears from CAR T-cell patients, and you can see here the morphology is distorted. Like when you look at the T cells, these are definitely not T-cell lymphocytes. These are definitely not normal lymphocytes that you would expect in the blood. The third point is that when we took an infusion product of CAR T cells, right, and we looked under the microscope, it took a lot of work to sort of set up the system, but when you look under the microscope, you can see that we stain, these are CD4 and CD8 T cells, and we stain them for an activation marker. So CD69 is activation marker. So these are from the CAR T cell bag. You can see that the activated lymphocytes in the T cell bag has a basophilic cytoplasm compared to the non-activated T cells that we're seeing there. We can't say if it's a CAR T cell or not, but it's still, it's an infusion bag, so at least some of them are CAR T cells. But anyway, so all of this sort of support our hypothesis that lymphocyte morphology could be an interesting tool to actually monitor CAR T cell therapy. And to sort of study this hypothesis, what we did is look at CBCs collected between day 0 to 30 in CAR T cell patients treated in MSK, like all commercial CAR T cell cells. Now, approximately 25% of these CBCs are reflected to a machine called CellaVision. And what it does is it essentially creates peripheral blood smears and then stores the cells. It's curated and stores the cells as the cell's images. So we have digitalized blood smears for approximately 25%. It's actually even more from the CAR T cell patients. Now, this is biased because not all CBCs are reflected, but a vast majority are. And the reasons that CBCs are reflected to this machine is usually there is something abnormal in the CBC. And many of the CAR T cell patients have some sort of abnormality in their blood smears because they get chemotherapy and these are not completely normal CBCs. Then what we did, and I'll show you later, is have a team of 2 pathologists go over these cells from the smears from we took about 2,000 cells from CAR T cell patients around day 0 to 14, and we asked them to classify the different cells that they see, to group them just by this is completely manual. We ask what do you think this cell belongs to, this cell belong, and they sort of define different morphotypes, which I'll get into soon. And then we trained a neural network to automatically classify these cells, to identify these cells automatically from the CellaVision images, and then you could apply it in scale, right? So because it's not realistic to have a pathologist sort of do it manually on each cell from the peripheral blood smear. So let me show you first. So these are the different morphotypes or lymphocyte types that our pathologists identified or defined after CAR T cell infusion in the first days after CAR T cell. So we see here the SRL is like small round lymphocytes. This is a typical lymphocytes. Then you see some granular lymphocytes or LGLs, large granular lymphocytes. These bleb-like cells, we call them disrupted cytoplasm lymphocyte. And then this very weird cell, which you may have called it a blast, but our patients usually do not have blast time of infusion. We call it an ABL, or a typical basophilic lymphocyte. So this was, identified in the smears, about 2,000 cells. We trained and validated a classifier to automatically classify these using a neural network, and we got reasonable good accuracy. And then, right, the next step, we could actually apply it not on 2,000 cells, but now we have almost 400,000 cells from about 540 patients treated with CAR T at MSK between day 0 to 30. And what I want to show you is this UMAP is sort of a way to reduce the dimensions or to sort of simplify the way we view very complicated data. And what I want to show you here is that when we sort of project this cell types on this UMAP, you can see they cluster together, meaning that the cells are closer to each other, the cells from the same group are closer to each other than from other cell groups. That sort of supports the robustness of the classification. Then we could sort of, ask question, do we see a difference between the expansion phenotypes across products, right? So this is bin days from infusion. You see here 0.1, essentially day 0. So the lymphocytes, we're clustering that goes to 0 at that point, time point. That makes sense because patients get chemotherapy, they get lymphodepletion, and then you see there is a contraction and expansion. And I want to show you, right, remember these ABLs that look very weird? So we suddenly see a window which we didn't see before CAR T, in axi-cell and also in lyso-cell, around day 6, 10, where it's peak CAR T cell expansion. We see other cell types as well here. And we could talk about the different morphotypes that are associated with different products. I won't go into that, but you sort of get the concept. We could sort of model different lymphocyte subsets or morphotypes across products. We could also look at the relationship with toxicities. We were able to show that building a machine learning algorithm to predict CRS or ICANS, we could show that it has some mediocre predictive capacity for CRS and ICANS. We could look at the cell importance, and again, I won't go into this currently, but what it tells us, even if this is not, and take my word for it, it's the AUC of 0.6. It's not a perfect classifier. It still tells you there is something informative in the cell morphology about prediction of these toxicities. So, and our hope is essentially to develop this tool to be an accessible way to actually monitor CAR T cell therapies and cellular therapies at large. And I think probably this is the last project I would sort of touch on, or it's actually a few projects combined. But as I told you, one major barrier that we have in CAR T cell therapy, in large B-cell lymphoma treated with CAR T cell therapy, is relapse. Approximately 50% of patients relapse or progress after CAR T cells. And when they do progress, their outcomes are dismal. So we want to understand why they progress and what's the drivers there. And here is another example how we could use machine learning or AI to get some insights about biology and risk stratify our patients. This is work done by Sandeep Raj from the lab, where we looked at day 0, so day of infusion, cytokines and labs from around 150 large B-cell lymphoma patients treated with commercial CAR T cells. And we used an unsupervised learning approach. It's called Gaussian mixture modeling, where we looked for clusters, for patterns, right? We have 14 labs or cytokines. It's very difficult to sort of make sense of it. So we asked the computer, okay, find us patterns in the data. And we call the model Inflamix. You'll understand why in a second. But we were able to find, using this unsupervised approach, so agnostic to the outcome, we were able to find 2 clusters. One that was highly inflamed, meaning that had high IL-6, ferritin, TNF-alpha, and one that was non-inflamed. And when we applied the signature, this is calculated in day 0 across multiple cohorts. We had approximately 700 patients, various iterations, various cohorts. We saw that patients falling into the inflamed group at day 0 had considerably shorter OS, or overall survival, progression-free survival, lower response, and this was disease agnostic, product agnostic in the scope of lymphoma. And even we show in the manuscript that it's agnostic to the tumor burden, which is obviously correlated also with inflammation. And more recently, So we found this informative signature. It started with unsupervised learning to find patterns, and then we show it has clinical significance. We were also able we can calculate this Inflamix at different time points. So we calculated initially at day 0 around infusion, but we could calculate it at times of the T cell collection. I remind you that we collect lymphocytes and then virally transduce them, as we discussed earlier. So patients could move from one group of inflamed to non-inflamed, from non-inflamed to inflamed. And what we were able to show is that if a patient started here in inflamed and moved to a non-inflamed peri-infusion, this is a broken orange line, they did as well as patients that remain non-inflamed throughout. While patients, either remaining inflamed from apheresis to infusion or becoming inflamed after, did considerably worse. So this provide you some rationale for actually interventions for reduction of inflammation. I'll probably, for sake of time, I'll probably skip some of this, but I want to show you that it's this inflammatory grouping, the Inflamix model actually held in the ZUMA-1 and ZUMA-7 studies, where patients in day 0 in the inflamed phenotype actually had considerably worse progression-free survival. And then we were able also to look a bit more in mechanisms, and we found that in biopsies from patients who are inflamed, there was less T cell infiltration, and there was a dampered CAR T cell expansion in the inflamed group. So we think these are potential mechanisms that drive this phenomenon of lower PFS, lower response in the patients who are inflamed. So, I showed you a lot of information, but ultimately, we have patients and we need to decide. And I want to show you here two LBCL patients that are very similar, like two males. One is 53, one is 68, good performance status, transformed diagnosis. One is GCB, the other is non-GCB subtype. Both are inflamed. Both have a relatively high tumor metabolic volume. And both received Axi-cel. One did not achieve a CR, one achieved a CR. And then the question is, okay, why are they different? I mean, they're similar in so many ways. So to study that, we compiled a very extensive cohort profiling multiple modalities, whether it's clinical, cytokines, radiomics, whole exome sequencing from the tumors, flow cytometry from the tumors. And we first asked, can we use machine learning to study each of the individual modalities to reveal novel insights on resistance and biology. And for instance, we started with this is the clinical features of the large B-cell lymphoma treated with CAR-T, and we found, for instance, that this is just ranking the variable importance in the prediction. We found that that's not surprising, but patients coming with stable or progressive disease at time of infusion, that was an important feature in determining the outcome. This does not show you the direction, whether it's poor or not, but you can assume that this is a bad prognostic factor. We found that, for instance, patients receiving systemic bridging had worse outcomes. And there are some other features here, but this is not as interesting, I would say. We could then look at the labs and cytokines, and again, when considering this, again, unimodal, each model separately, we found that LDH was very important in predicting outcome. Well, again, this is not a big surprise for the clinicians, right? Hemoglobin, CRP, and some of the inflammatory markers, and we showed that previously. So again, not a big surprise. But then we ask, let's look at some different modalities. So we developed a pipeline to abstract body composition from the PET scan. And we find, for instance, that high visceral fat is associated with worse outcome. We could then look at specific radiomic features and found, again, various sort of individual factors associated with worse progression-free survival using this unimodal approach. We could look at the whole exome sequencing that we had pre-CAR-T on these patients. And then, for instance, we found that markers of genomic instability were associated with lower PFS in this population. So patients with a genomically unstable tumor essentially had shorter PFS. We could look at the flow, and there we found that sort of an exhaustive T-cell phenotype was associated with worse response. So we have these, all the individual features, and now when we actually look at what are the, we add sort of non-standard data on the patients that you saw earlier, you see that patient A actually had a TP53 mutation. It had a certain radiomic feature, had a lot of visceral fat, had a lot of genomic instability compared to the patient B. And this could have informed us, if we had known that before, could potentially inform us better on the outcome of patient. But ultimately, the sort of holy grail is to combine all these different modalities to one predictor and see whether we could identify who would benefit most from the CAR-T and maybe identify also novel predictors. Again, without going too much into the technicality of that, Dr. Tang Fei developed a method we call multimodal mixture modeling, which the benefit is that it could take modalities that we don't have full data on. Let's say we don't have whole exome sequencing for all data or all patients. So we could still consider these patients that we don't have modalities in the model and assign a prediction. You get like a fine for that, but you are still using all the data. And using this method, we could explore what are the important factors in predicting outcome. And we found that there are different predictors when you look at multimodal models, meaning combining multiple modalities, versus looking at single modalities separately. For instance, when we looked at the multimodal approach, we found that a mutation in SOXS1 was associated with worse outcome, that the liver density, so lower liver density was associated with worse outcome. And then there are other features here as well. So you can glean or get different insights using this multimodal approach. This is a bit preliminary, but what I'm showing you here is that essentially combining the different modalities together actually gave you better predictive performance compared to just considering single modalities. So in summary, I think we see that resistance and toxicity still remain major challenges in CAR T-cell therapy. CAR T-cell toxicities are interdependent. They have form distinct clusters and share specific biological pathways. We were able to show that systemic inflammation captured by inflamex is reproducibly associated with poor outcome and may be modifiable. We exemplify how we can use AI to potentially look at lymphocyte phenotypes after CAR T cells and maybe monitor the treatment. We have used AI to integrate multiple modalities to derive novel biological insights and clinical insights and enhance our ability to predict CAR T cell therapy. And I think with that, I'll end and thank first and foremost the patients, and then a huge team. This really involves so many people that I'm very grateful to, and our collaborators and funding agencies, and I'll be happy to take questions. Thank you.
Awesome. Amazing.
Thank
you very much,
Amazing.
Ronnie.
Yeah, I mean, this is one of the best talks I've ever heard in clinical applications of AI, to be honest. Thank you.
Thank you so much. Thank you.
Awesome. So thank you, Ronnie. So now we're open for questions. We have about 15 minutes or so for open conversations and questions for Dr. Samir and Ronnie. So I encourage all of you to put your questions in the question chat if you have any specific question to both speakers. I could probably start with Ronnie. You have done amazing work, Ronnie, in putting moving mountains, just getting data together from multiple institutions to have like this large cohort of CAR T cells. I mean, that's amount of work is amazing. So to go to the first project, when you looked at the toxicities that are driven and the changes of the toxicities, have you looked before the patient get the CAR Ts in terms of like adding the clinical characteristics and the disease characteristics, the type of CAR Ts, and then correlate that with the amount of toxicity in a continuous way before they get the therapy? Because the question, would you identify your high toxicity cluster before they get the therapy?
Yeah, I think that's sort of a critical question. And I think we sort of have static models and we have the dynamic models. And the gist is, I think that the dynamic models seem to do better when you sort of provide more information. But obviously we would like to, we get some sort of base prediction, I guess, just looking at, let's say, lymphodepletion, pre-lymphodepletion, but it gets better as you expose the model to more information. So I think ultimately what we'd like to do is, inform. Ideally, the way I see it is, for instance, you start the procedure outpatient, right? And then you just monitor the patient. You sort of say, okay, if it's very high from the get-go, let's admit them, right? And if you start monitoring day by day and say, okay, tomorrow, I think, this patient is going to develop CRS or ICANS. Either we admit them, we give them steroids, we monitor them more closely. So this is how I see, but I do think there is value in dynamic monitoring here.
Awesome. And then the question always, I guess the challenge of AI, one of the challenges is how do you take this great work in research and make it applicable or deploy it, right? Because yes, I mean, we all agree that monitoring throughout and then making those decisions, but you take this model and integrate it in the clinic. Have you tried to do that? And if you try to do that, what happened? How would we move it to the clinic?
Yeah, I think we both sort of experience the pains of bringing things to the clinic. We haven't tried this yet. I think the key, what I've learned is to sort of try to keep it simple as much as you can, and not, try to use standard markers, standard measurements. And that's why I have a lot of belief, for instance, in the morphometric and the morphology analysis, where you're using cell vision, which is used across the US and actually across the world. In many centers, it's all such a standardized process. You don't need to think. So it has to be very deployable and simple. Like the best models are simple models. Um, for my experience, like most scores, I think you have published many scores, and it's hard to, and from my experience or the scores that I've developed, it's very hard to get them into the clinic because when clinicians actually have to go to the online calculator, enter it, it loses a lot of the access applicability. So yeah, I think the key here is simplicity, and then embedding it as part of the EMR is going to be very important.
Great. I guess I'll go to Samir. Ahmed, you have a question?
Yeah, ask Dr. Samir, and then I'll come after that.
Yes, I want to ask about just maybe, I know that the audience are in the region, but what for my own education, what is the application of CAR Ts in Saudi Arabia? How many CAR Ts do you do per year, and are all these commercially available CAR Ts that Roni talk about available?
Okay, so in Saudi Arabia, actually, we're talking here about lymphoma, definitely. So we have Axicel and Tisacel. Lisocel is not available in Saudi Arabia. Yeah, and also we have as an information Broxacel also. Okay, in case of mantle cell lymphoma or acute leukemia. So how many centers? So in Western region, we have only the National Guard Jeddah, Riyadh, National Guard Hospital in Jeddah. There is a CAR T cell in Riyadh. There is the National Guard Hospital in Riyadh, and King Faisal Specialist Hospital in Riyadh, and King Fahad Medical City. They do CAR T cells. Like, let me talk about my institution. So until we started the program 2 years ago, so until now we have maybe around 31 or 32 cases of the CAR T cell. Yeah, this is and based on the presentation of Dr. Roni, actually, it's very important because we face this actually challenges. Some patients actually, they develop the severe CRS and did not achieve any CMR. And actually, when the opposite side, there's some patient develop grade 1 or 2 CRS, in the day 30 or day 90, still complete metabolic response. And the third group, they develop CRS, but there is no response at all. So this, I think, is very important because we don't know the activity of the CAR T cell on this disease. Is it because of infection or CAR T cell is active? Do we need to use prophylaxis dexamethasone, especially in elderly or high burden disease? Would that affect the outcome of CAR T cell or not? So all these questions not yet answered, unfortunately.
Yeah, Dr. Alamoudi, I want to sort of echo that your thought about, are all CRS created equally, is one of the questions that sort of set us off to this project, because we thought, my hypothesis at least initially is that it's sort of have some graft versus host disease. It's good, in a limited amount, and then I actually thought it would be the same with CRS, but we did not find that. So it's more complicated than that, and maybe these toxicity phenotypes could help us sort of understand better, are there certain toxicity syndromes essentially that are associated with better outcome, and we were looking at that. Yeah.
I guess I can jump here. I have several questions. I'll see if we can try to squeeze them with whatever left. First of all, excellent work. I mean, tremendous. And I guess many questions that could be asked. One of them is, for the audience, the method that you've posted, the latent trajectory clustering, obviously stems from the fact that you cannot rely on snapshot data collection on those patients, and you need a dynamic data collection and then thus the model would improve the more data you collect and the more dynamic the patient becomes. Then the question is, how do you foresee the future? Do you think those models will be frozen when they get commercialized, or they will continue to learn when they are commercialized? Because at the end of the day, the data will still be coming in. Would the models be best performing if they are built in a way that they continue improving, or are they going to be frozen for whatever we've reached and then they are applied? How do you foresee that? And especially that those are tested not all over the world, obviously.
You're totally right. And I think, this sort of data drift is a problem for any of the, I guess, for machine learning in general. I know that, for instance, in transplant, I've worked previously on prediction models in that area, and the field now is completely different, right? There is PTCY, everyone's doing different. So there are dynamics, and then centers are getting better, let's say, on managing toxicities, and we see less toxicities. So ultimately, it's going to have to be like a continuous process of feedback. We are trying, I must say that that one of the reasons we really have a large cohort and we increased it is to sort of support generalizability. And we have different practices, different areas in the world, different products, obviously. And I hope that would contribute to the robustness of the model. But every now and then it would still need to be sort of checked and revalidated. You have to see how it changes. I think that now with sort of commercial CAR T cells, maybe it's stabilizing a bit around second line, so the cohorts will start to be a bit more homogeneous. But yeah, it's a challenge, and we should always keep collecting the data and checking ourselves for sure.
I guess you wrote a paper, if I remember, with a couple of years ago, in 2023. You called it the sum of all parts, if I remember correctly. You talked about the downside of the comorbidity scores. So maybe in the future you will start talking about the downsides of the AI models and prediction. But my
you
second
become a bit skeptical when you sort of do more and more of that. You have to you become more cautious, I would say, in how you interpret that. You have to be very careful. Yeah.
The second question is, as I was fascinated with the last work that you've presented. I mean, let me call it, I know it's not supposed to be called this way, but let me call it the AGI model for cellular therapy. So let's say it's a general intelligence model that lumps all those models together under one umbrella. Because at the end of the day, that's what you probably will be hoping for, that comes one day. You have like one model that helps you in all your cellular therapies, from outcomes, toxicities, complications, and so forth. But the way the question in my mind would be, how are those, because each one of those models is developed separately. So how are the models will be affecting each other? Like if you combine them under one big model, how would they be affecting each other, if any? Because they share many of those data points, and many of the analysis actually shared between different models. So if you are combining them, how would that be affecting the output?
You're talking within like in the model development phase, essentially?
Yes, yes.
Yeah. So I didn't go too much into details, but we are so the approach we're using, which we call MMM or multimodal mixture modeling, is what we call there are architectures of multimodal learners, I would say. And there is what we call late fusion, early fusion. The late fusion means that you take each model separately and then combine them. And this is sort of what we're doing. The benefit of this method is that we could still generate a prediction even in the absence of a certain modality. So the modalities do not affect one another to that extent. I think another element that I did not sort of touch on with this method is that we also have a feature which is called modality importance. And the idea there is that if for certain patients, one modality will be more important than the other. And the assumption that all patients will have the clinical modality, clinical data, but not all patients will have whole exome sequencing or the flow or whatnot, right? So we learn essentially which modality pairs the patient features, which modality are most important. And for and I'll give an analogy, let's say from transplant, where let's say you have an AML patients going into transplant, and the patient is completely refractory to all treatment line. The patient never saw a remission in his life. So for that patient, it doesn't really matter what the genomics are, what the cytogenetic, right? You know, this is a bad player no matter what. While you have in, AML patient, CR1, normal cytogenetics and has a FLT3 ITD mutation, but then, has or an NPM1 mutation, but then had a KRAS mutation or a c-KIT mutation or whatnot, then, for this patient, it would probably be more sense to attribute more importance to the genomic feature. So this is sort of the concept. But we're not, the models or the modalities do not affect one another.
Aziz?
I guess we're up on time. It's really was amazing and a great pleasure to have both of you here with this amazing work. And this is our fifth now time that we hosted this. We have a great audience, and we really thank all of you for attending today. Thank you, Ahmed. Thank you, Samir. Thank you, Ronnie. It's just a great meeting. We want to also thank the sponsor of this event, Sanofi, who made it possible for us. Ahmed, you have a few words at the end?
No, thank you. Thank you. That's pretty much it. I guess one question that came, we'll just end with that. Are you aware, Ronnie, of any models that's specifically in terms of chronic GVHD prediction, any models that somehow implementing patient-reported data, so pictures, patient-reported outcome or symptoms in early prediction of GVHD or prediction of response?
Yeah, so yes, there is. It's a great question. There is, if it's okay, I'm gonna hijack the the screen for a second. This is a part, oh wait, which I did not get to in the talk, but there is here, this group actually looked at rashes of patients of allo transplant recipients, and then the algorithm was supposed to classify whether it's a chronic GVHD related rash or not. And it's very preliminary, but it achieved some interesting or a favorable accuracy. So, by the way, the one area or the one type of patients that did not reliably classify as patients with darker skin. And this is sort of tells you something about bias in machine learning. We actually used in this study, we developed a machine learning model for a time to event outcome based on a saliva or stool samples from transplant recipients. And we were able to sort of, in the manuscript, we sort of show how we can use clinical features or microbiome features to predict a chronic GVHD, oral chronic GVHD. It's very interesting in the context of saliva. I'm not aware specifically of patient-reported outcome. And I'm not familiar with other models that are actually predicting chronic GVHD, aside from this one. But yeah, I think this is also an interesting sort of unmet need that we should investigate more.
Thank you. Yep, yeah, that was like the dessert at the end. So thank you very much. And again, thanks for all. Thank you, SSBMT. Thank you, Sanofi. And we'll see you next month, hopefully. You'll receive email regarding the next month webinar, hopefully in the next couple of weeks. So have a great evening, and thanks for being with us tonight.
Thank you, guys. Thank you.
Thank you so much.
Bye.